All right, now we're dealing with wide irregular tachycardias. What could those rhythms be? Well, it's usually atrial fib with a bundle branch block, which is just plain old atrial fib with RVR treatment, and it's kind of boring, and it's no big deal, and calcium blockers work just fine, and it's all very safe. But it's possible that it's a great big hairy scary big deal that is atrial fib with WPW, atrial fib with an accessory pathway such as Wolff-Parkinson-White syndrome. And if you use your usual treatment for atrial fib with a bundle branch block, and you use vagal maneuvers, or you use cardizem or amio, you can kill them. So it's not okay to be clueless on this deal. There's a few times in your career where you're going to run into a very difficult situation, and this is one of those, I think, where the usual treatments don't apply. And you may see this once in your career, you may not. But we learned to do cricothyrotomies, so we need to figure this out as well. So here's the deal. If your patient's unstable, then we're going to do unsynchronized cardioversion. We're going to do that at 120 joules, and we are actually going to defibrillate a patient with a pulse on purpose, and according to guidelines, teachings, and standards, we must unsync cardiovert the unstable, wide, irregular tachycardia patient. What if they're not unstable yet? Well, we need to figure out which of the rhythms it is. So this is a case where we're going to need to check for atrial fib with WPW. And we're going to hope that we find atrial fib with a bundle branch block, because that's the usual treatment. Vagals they're fine, they may not help, but go for it. Calcium channel blockers, diltiazem will work. Beta blockers, if you have the right ones, will work. And amiodarone will take forever, but it'll finally work. And so atrial fib with a bundle branch block, if that is what your wide irregular tachycardia is, and that is fairly common, much more common than the scary one, then it's really not that scary. But we want you to check every time and don't just roll the dice with your patient's life. So what do you do if it is atrial fib with WPW? Well, first of all, get very scared. Secondly, put down all your medications unless you have procainamide. If you got procainamide, that's cool, it'll work, because it blocks the bypass track. It blocks the accessory pathway. It doesn't mess with the AV node. We cannot block the AV node. Adenosine blocks the AV node. Diltiazem and calcium blockers block the AV node. Amio blocks the AV node. Beta blockers block the AV node. We can't do that, or we end up sending all of the atrial fibs right down the accessory pathway. And we bypass the AV node's protection of the ventricles. The AV node is protective of the ventricles because it keeps atrial fib from becoming ventricular fib. Ventricles don't like little fibby waves coming at them at 300, 400, 500 times a minute. They don't like that. They don't do well. We have to protect the ventricles. The AV node does that unless we take it out. So if we block that AV node even a little bit, then all the fibby stuff runs right straight down the bypass track and we create VFib. So it would be extremely important to your patient that you be able to name the three things that would identify atrial fib with WPW, and these are not the same as the three things that help you identify an accessory pathway. Accessory pathways like WPW, the three things that you should be able to say for regular WPW, not atrial fib with WPW, but sinus tach with WPW or SVT with WPW. WPW has a wide QRS, a long PRI, and a delta wave. But with atrial fib with WPW, you can't see the PRI because there's no P waves. It's atrial fib, so there is no PRI. And you may not even see the delta waves. Remember to look in all 12 leads, but you still may not be able to see them because these rhythms are kind of junky and hard to figure out anyway. And so you may not even see the delta waves. So that just doesn't work for atrial fib with WPW. You've got to have these three things that you must know. First of all, it has to be a wide irregular tachycardia. That's how we got here in the first place. Secondly, it must be polymorphic. So it's going to be irregular in terms of its rate. It's also going to be irregular in terms of its shape. Polymorphic. And there's going to be periods of just crazy fast ventricular rate approaching 300 or more. So the atrial rate is going to be out of control, 300, 400, 500 times a minute. That's fibrillation. But now sometimes all of those are being transmitted to the ventricles, and you're getting this crazy fast ventricular rate that may be approaching 300 or more. So you've got to know those three in order to protect your patient. Again, morphology is not the same as regularity. We sort of talked about that. Things have a different rate versus things having a different shape, but it's important to bring that up. And we bring that up and emphasize this because it has been a point of confusion for some students. So how are you going to proceed here? Well, you've got to have a 12 lead. And so with narrow regular tachycardias or wide regular tachycardias or narrow irregular tachycardias, you don't need a 12 lead before you treat. At least you don't need a 12 lead before you give meds. But in the case of a wide irregular tachycardia that's not unstable yet, you've got to get a 12 lead because you've got to look for those three things we just talked about. You've got to look for the polymorphic pattern, and you've got to look for the crazy fast rate. If a patient's unstable, they get unsync cardiovert. It's that simple. We defibrillate them. But if they're not unstable yet, get a 12 lead and look for those three things. So here's some examples. Here's atrial fib with a bundle branch block. This is what you usually get with a wide irregular rhythm. A lot of people have atrial fib. A lot of people have bundle branch blocks. Some people have both of those at the same time. This is what it looks like. It is irregular, but it is monomorphic. Now, while we're looking at these 12 leads, remember that if you're looking for monomorphic or polymorphic, you have to just look at one lead. Clearly, it has different shapes and different leads, but we're talking about the same shape and the same lead. It's irregular, it's monomorphic. That's A-FIB with a bundle. This, on the other hand, is irregular and polymorphic. Again, different shapes within the same view, and particularly the lead 2 rhythm strip at the bottom that goes all the way across this 10-second wide 12 lead. Look at what you've got. You've got 3 or 4 different shapes in addition to irregularity. And so atrial fib with WPW is going to be a big deal for you to catch. You must not give any medication that slows that AV node. You'll take out the protection of the AV node, and we can't have that. So no adenosine, no dotiazine. It's the very same slide as before. Put your meds down unless you've got procainamide. If you've got procainamide, use it. But if you don't, no meds are appropriate for this patient.